Everyone, and welcome to the annual Perinatal HIV Roundtable. I am so pleased that you're able to join us. Thank you for putting your names in the chat. I see people joining us from all over the place. I see Scranton, Pennsylvania. I see Mississippi. I see Baton Rouge. I see Rustington, England. I see Chicago. Thank you so much for taking your time on a Friday afternoon to join us. I'm really thrilled that you're here. My name is Marlisa Warren. I am the project manager for the Perinatal HIV Hotline, and I am going to be one of your moderators. My co-moderator, Olivia Ford, the amazing and wonderful Olivia Ford, will be introducing herself very shortly. This year's theme is the HIV and infant feeding guidelines at 6 months, perspectives from national leaders. And we are beyond grateful to have such amazing speakers and panelists join us today. And I want you to be able to appreciate the full depth of their experience and expertise. So we've created a document with their bios that we're going to drop in the chat so that you can explore them at your leisure. We're not going to do lengthy introductions today because we want to leave a lot of time for discussion, but please take a moment to review their bios when you have an opportunity. Next slide, please. I do want to acknowledge the amazing support we receive from the Health Resources and Services Administration. We absolutely could not do the work that we do without their support and sponsorship. So thank you. And today's agenda. So I'm going to take just a minute to walk you all through the agenda for today. Doing introductions and housekeeping right now. I'll take us through a land acknowledgement in just a moment. The wonderful Dr. Judy Levison will be walking us through the HIV and infant feeding guidelines as they stand now. We will also be taking the bulk of our time to go through a panel discussion with our panelists having an interactive interview discussion with each other. There will be time for Q&A after both Dr. Levison's section and the panel discussion section. And then we'll be moving into breakout groups. I want to really encourage everyone to stay for the breakout groups. The veterans of the previous roundtables will probably agree that this is the most enjoyable and important section of the rounds table. It really provides an opportunity for folks to have discussions with their colleagues about difficult and thorny issues. So we're hoping to provide an opportunity for that today as well. Next slide. For our land acknowledgement, UCSF has a standard land acknowledgement, which is in front of you. I will leave it there for you to read. I am in San Francisco, and I sit on Ramaytush Ohlone land that is currently unceded. And I also want to invite folks to remember that there are lots of ways to stand in solidarity with the Indigenous communities that we live with and among, and that some of the ways to do that, in addition to learning more about the Indigenous communities where you live, is to explore other options for volunteering or supporting efforts of Indigenous communities. Some of the efforts in the Bay Area include rematriation efforts, which are led by Indigenous women. I'm dropping in the chat the Sogorea Te Land Trust, which is one of the rematriation efforts in the Bay Area. Next slide. And finally, the Perinatal HIV Hotline is one of many services offered by our umbrella organization, the National Clinician Consultation Center. I encourage everyone to take a picture of this slide. It will prove useful when you have clinical questions that you want to discuss, you can always give us a call at one of our services. And now I think I'm going to pass it over to Olivia.
Yes, thank you so much, Marlisa. I hope everyone can hear me. As Marlisa mentioned, I have the honor of co-moderating with her today. My name is Olivia Ford, she, her, they pronouns, and I am also a proud member of the staff of the WELL Project. I'm the editorial director for the WELL Project, and we are co-presenting today. For folks who aren't aware of or are less familiar with our work, we are a nonprofit organization whose mission is to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls across the gender spectrum. We have done quite a bit of work in past years at the intersections of HIV and perinatal experience and sexual and reproductive health, and of course, breast and chest feeding, which is how we come to this this work and this event today. Thank you all so much for being here. It's wonderful to see that so many people are committed to this area of their work and supporting birthing parents living with HIV. I forgot to mention, I am located on Canarsie and Muncie Lenape land, colonially known as East Flatbush, Brooklyn. And I believe that next slide, please. I think it's not that. About that time. Yeah, so I just wanted to kind of lay out kind of a set of agreements that we can all kind of do our best to adhere to while we're sharing this space together, just recognizing that you know, this event is really unique in that it's geared toward providers and welcomes all folks who have an interest and a kind of stake in this topic, recognizing that and just the wide variety of lived and living experiences in this in our virtual circle. I just want to encourage folks to you know, avoid jargon, say full terms along with their acronyms. Just think of what you knew prior to having the role that you currently have, and if there are things that you might not have known 10 years before you became, say, a physician or something of that nature, maybe kind of add a little bit of context to the terms that you're using, and unpacking concepts a little bit that may be very specific to your discipline so that we can all learn from each other. It kind of facilitates us all learning from each other. Another huge aspect of the WELL Project's work and the work of many organizations here and that we work with is encouragement to use respectful person-first language, avoiding just changing a person with HIV or a person living with HIV in exchange for HIV infected. I am going to, I don't know if Leela has shared the link, but we have a very extensive resource on our website around people first language and just respectful language. Thank you very much, Leela, in HIV work. And so feel free to take a look at that for a refresher. And yeah, lastly, we just invite folks to be curious, just be mindful of the depth and also of the limits of your knowledge and of your expertise, and just being open to the just really dazzling and really exciting range of perspectives and forms of expertise that are represented in this quite large circle today. Oh yes, and just break out a little bit more when we actually get to that point. But just know that once you're in them, you can always come back to the main room for an SOS. Next slide, please. So without further ado, I have the honor of introducing Dr. Judy Levison, who is going to be our first speaker and give an overview of the topic we're here to discuss today and the history there. Dr. Judy Levison is a professor in the Department of Obstetrics and Gynecology at Baylor College of Medicine in Houston, Texas. She's on the National Perinatal Guidelines panel and provides consultation for the National Perinatal Hotline. Her group is the first in the US to develop a curriculum for group prenatal care for women living with HIV and to follow the outcomes of this program. And it's, again, just a pleasure and honor to work with her, and she's just been so instrumental to so much of the work in this area. Dr. Levison, thanks so much for being here.
Thank you, Olivia, and really, I am honored to be a part of this group. So we'll be talking today about the new recommendations for infant feeding and how we got where we are today. Next slide. So I want to give you some history just to get everyone on the same page. Prior to antiretroviral therapy, the risk of perinatal transmission was 25%. And in this case, when I refer to perinatal transmission, I'm talking about transmission from mother to child during pregnancy, labor, and delivery, and not including the breastfeeding. With zidovudine during pregnancy and labor, and for the infant with prophylaxis after delivery for 6 weeks, the transmission dropped to 8%. Someone got brave and dared to give pregnant women antiretrovirals. And that was a 60% drop. Then as ART, so combined medications came in, transmission appeared to be less than 1%. And we now have evidence that with antiretroviral therapy and having an undetectable viral loaded conception throughout pregnancy and delivery, and this is a study of over 5,000 mother-baby pairs, there were 0 transmissions. Next slide. So then to focus on infant feeding, what has been the guidance around feeding choice for infants of people living with HIV? And this slide is thanks to Ted Rule. If we go back to 1985, the MMWR came out and said, and this was when HIV had a different name, HDLV3/LAV, infected women should be advised against breastfeeding to avoid postnatal transmission to a child who may not yet be infected. It's really very negative language. Then in 2015, and this is kudos to Leela Pollack too, she and I worked to get some acknowledgement in the perinatal guidelines that there were women who were breastfeeding. And up until then, there really had been, it was just said, don't do it. And so we were allowed basically a sentence, and that was, in discussing the avoidance of breastfeeding as the strong standard recommendation for HIV infected, and again, I'm cringing at almost every other word, women in the United States, the panel notes that women may face social, familial, and personal pressures to breastfeed despite this recommendation, and that it is important to begin addressing possible barriers to formula feeding during the antenatal period. So that was, little did we know, that was the foot in the door. Next slide. And then in 2018, we were asked to draft an entire section related to infant feeding. And it still has a lot of negative language, but it's the first time, though, again, that there was an acknowledgement that this is what people are doing. Breastfeeding is not recommended for women living with HIV in the United States. Women who have questions or who desire to breastfeed should receive patient-centered, evidence-based counseling. When women with HIV choose to breastfeed despite intensive counseling, they should be counseled to use harm reduction measures to minimize the risk of HIV transmission to their infants. And though this felt like a great leap forward, again, I still cringe reading this. So go ahead to the next slide. And then by 2022, we started having much broader discussions, and many community members on this call contributed more than they may really know to expanding the conversation. And so on January 31st, and you don't need to read the fine print because I'm going to go through that, January 31st of this year, the most recent guidelines were released. Next slide. So what is the major change? The primary recommendation is now to support parental choice through shared decision-making, rather than a specific infant feeding mode. Next slide. And here are some of the things that we thought about as these guidelines were being developed. One was the health benefits from breastfeeding. For the infant, lower risk of infants developing asthma, obesity, type 1 diabetes, respiratory disease, otitis media, sudden infant death syndrome, gastrointestinal infections, and necrotizing enterocolitis. For the breastfeeding parent, decreased risk of hypertension, type 2 diabetes, and breast and ovarian cancers. There were equity considerations. Black women are disproportionately affected by HIV in the United States. People of color experience a greater burden of many health conditions that may be alleviated by breastfeeding. And cultural considerations. Environmental, social, familial, and personal pressures to consider breastfeeding, and fear that not breastfeeding would lead to disclosure of their HIV status. Next slide. So what is the risk of HIV transmission via breastfeeding? What we know so far is that without maternal antiretroviral therapy or infant prophylaxis, the risk of an infant acquiring HIV through breastfeeding is 15% to 20% over 2 years. And that's too high. Achieving and maintaining viral suppression through ART during pregnancy and postpartum decreases breastfeeding transmission risk to less than 1%, but not 0. Next slide. So knowing that, here are some of the main points in our overview of counseling and management. And we really want to emphasize what is on the left, which is for people with HIV who are not on ART and or do not have a suppressed viral load at delivery, replacement feeding with formula or banked pasteurized donor human milk is recommended to eliminate the risk of HIV transmission. So we're not saying everybody come and you are welcome to breastfeed. It's think about it and decide if you are a good candidate. Individuals with HIV on ART with a consistently suppressed viral load during pregnancy, and so we were saying at a minimum during the 3rd trimester or the last 10 weeks, and at the time of delivery should be counseled on the options of formula feeding, bank donor milk, or breastfeeding. And we recommend saying to people the infant feeding options that eliminate the risk of HIV transmission are formula and pasteurized donor milk. Fully suppressive ART during pregnancy and breastfeeding decreases breastfeeding transmission risk to less than 1%, but not 0. And there are studies suggesting as low as 0.3% or 3 per 1,000. Next slide. And we also have dealt a little differently with the issue of intermittent use of formula. And that has been a controversial issue. And the reason for that is that in 1999, a study was published showing that, and this is prior to antiretroviral therapy, and I really want to emphasize that prior to antiretroviral therapy, that showed that exclusive breastfeeding was associated with less transmission than going back and forth between formula and perhaps even solids and breast milk. And we are now over 20 years later with good antiretroviral therapy, and no one's going to do the study, but there's a lot of reason to believe that the risks that existed in 1999 do not exist now if someone is on ART. So we say if breastfeeding is chosen, exclusive breastfeeding up to 6 months of age is recommended over mixed feeding. And that's what's recommended for people without HIV too. And when we say mixed, we're saying breast milk and formula, acknowledging that there may be intermittent need to give formula. For example, infant weight loss, milk supply not yet established. And I think many of us have encountered that situation. Mother not having enough stored milk. Solids should not be introduced, or it should be introduced as recommended at 6 months of age, but not before. Next slide. And then there are situations to consider stopping or modifying breastfeeding. In the case of a detectable viral load, breastfeeding should be temporarily stopped. Options include giving previously stored breast milk, pumping and flash heating, providing replacement feeding or cessation of breastfeeding, repeating the viral load and reassessing continuation or cessation of breastfeeding. If the repeat viral load is detectable, the panels advise immediate cessation of breastfeeding. This guidance is more directive than the general counseling for individuals on suppressive ART. And there is no consensus on ARV prophylaxis for infants of individuals with sustained viral suppression who are breastfed. Most panel members agree on only 2 weeks of infant zidovudine. However, several panel members prefer to extend the duration of zidovudine prophylaxis to 4 to 6 weeks if someone is breastfeeding. Alternatively, some panel members recommend 6 weeks of nevirapine. And then there are others who opt to continue nevirapine dosing throughout breastfeeding and even 1 month beyond. Next slide. One final point is that engaging Child Protective Services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. And Child Protective Services has been called and has even separated mother and child where a mother has been breastfeeding. Numerous pregnant people with HIV have reported that after expressing their interest or intention to breastfeed, their providers threatened to report them or actually did. And such engagements can be extremely harmful to families. They can exacerbate the stigma and discrimination experienced among people with HIV and are disproportionately applied to minoritized individuals, including Black, Indigenous, and other people of color. Next slide. So one other thing that was different in the process of developing the guidelines was, as I said, we integrated community input in ways we hadn't before, and that included members of the Well Project, the International Community of Women Living with HIV North America, and others. We had input from lactation specialists at CDC, and there was a new level of collaboration between the perinatal and pediatric panels. And I think this, even though it took a lot more energy and time, it was well worth it. And we came to a consensus that, and I really feel like all the panel members could live with where we landed. Also, and this is a shout out to Heather, CDC chose to refer any queries about infant feeding in the United States to the perinatal guidelines rather than having their own recommendations. And so rather than having, depending on what website you went to, getting different recommendations, everything now points to the National Perinatal Guidelines. Next slide. And then just finally, data are beginning to accumulate on breastfeeding in high resource countries. And there is a question, and a good question, from people in low resource countries. Well, why don't you just trust our data? Which I think is, again, a very good question. So we've had reports of a Canadian series of 3, Baltimore 10, Washington, DC 8, an Italian series of 13, German series of 42 and 30, Swiss series of 41. And our group just published it so far online. The in-print version should be out in the next few weeks. A series of 72 that includes some of the previously reported ones, but it includes 52 new cases. And there was no transmission in any of these cases. Next slide. So just some resources as you navigate this new road. One is the perinatal guidelines at hivinfo.nih.gov, the Well Project, and of course the perinatal hotline. And the beauty of the hotline is 24/7. You get a human being at the other end of the line. So if you or any clinician you know has a question, even at 3 in the morning, you can call this number. Thanks.
Thank you so much, and also perfect timing, Dr. Levison. Thanks so much for that. So as of now, we're running on time. And we have time for about 2 or 3 questions, and I see that there's about that many in the chat at present before we go into our panel conversations. So let's take a look. And also, yeah, I think that probably if we are, well, one is a comment, I believe. But I think one question, the first question was about pumped pasteurized milk. What are your thoughts about mom's pumped pasteurized milk in addition to the options from the outset?
So, and I think that's referring to the flash heating. Is that?
Yes,
yeah.
Yes, I believe so. Oh, and then
yeah.
The next question.
And I mean, there is evidence that it does eradicate HIV, and there are references to that in the perinatal guidelines to get a link to the exact methods and findings. And so the studies, the limited studies that have been done show destruction of the virus.
Okay, I believe the next kind of chat item is a comment, not a question. So I'm going to see if, again, we have time for maybe one or two more questions. Do we have any raised hands or folks who want to drop another question in the chat?
And I do see another question. If a viral load is very low, 50, is that considered enough to stop breastfeeding while waiting to repeat viral load? What ARTs are given to the baby? This is your guess is as good as mine, though. I would say 50, we really would consider less than 50 pretty much undetectable. And I honestly would not be worried about 50, but there may be clinicians who get anxious about that. So I think this is going to be something that has to be individualized. I would say call the perinatal hotline. And even though I work with them, I often call them just because I need another brain to bounce my thoughts off of.
Thank you so much. Do we have, let's see, another vote for the perinatal hotline in the chat? One more question, perhaps? Oh, we've got, so what are the infant testing guidelines if and while the infant is breastfeeding?
And that is in the pediatric guidelines, and it's basically initially following the same recommendations. And then, Leela, you can help me out on this, or Ted. I think it's a minimum of every 2 to 3 months while breastfeeding, and then something like 3 months and 6 months after cessation. But that's a paraphrase of what the actual wording is.
And then what I'd call sort of a companion question, but regarding the parent, should we increase HIV viral load monitoring while breastfeeding? So monitoring the breast or test-feeding parent.
And I think what we finally agreed on was saying checking viral load every 1 to 2 months. In our practice, we check or recommend checking every 2 months. So it's more, whereas most of our patients would be eligible for testing once every 6 months if they were not breastfeeding. We ask them to continue with every 2.
Okay, and let's call this the last question, and I imagine it's probably it's one with varied responses. How are meds for babies being funded?
That's a good question. And I might need a pediatric person to answer that, though we have never run into any objection to that. I just also would just want to say, I see somebody made the comment, good to give families the perinatal hotline. That's actually not true, unfortunately. The perinatal hotline is intended for clinicians, but the families can, if they are having problems with their clinicians, can say to the clinicians, I want you to call.
All right, thank you so much, everyone. With that, I am going to turn the pin over to my lovely co-moderator to introduce the to our first panelist pair. And Dr. Levison, thank you so much once again for your knowledge and wisdom.
Thank you.
Absolutely.
Yes, thank you so much, Dr. Levison. It's always a joy and a pleasure to have you present with us. Okay, so I am really thrilled to introduce our first panel pair. I, again, encourage you to read their extensive, amazing, impressive bios. I'm going to do just the briefest of introductions. I am delighted to introduce Sierra C.C. Coven, who is the program manager at the Well Project, and Dr. Laura Cheever, who is the associate administrator of the HIV/AIDS Bureau at the Health Resources and Services Administration. And is it okay if I jump in and ask you to tell us a little bit about yourselves first before you get started? Okay, so I would love to hear a little bit about your background and what brought you to this moment. And Cece, do you mind starting?
Sure. Hello, everyone. My name is Sierra Cece Colvin, and I'm a woman living with HIV. I've been positive since 2008. I have 2 children, and they are both HIV negative. We'll learn a little bit through the conversation today how I had the amazing opportunity to breastfeed my second child for 7 months and get the support to do that. So I'm really excited to jump into this conversation today.
Great, thank you. I'm Laura Cheever. I'm an infectious disease physician. I was going to go into international health, very interested in health equity, but trained in San Francisco in the early 90s and was completely taken with the important issues in HIV. So became an HIV clinician and subsequently went more into health policy. I'm at the Health Resources and Services Administration. I run the Ryan White HIV/AIDS program, the national level. And I really joined HRSA because I was so interested in how to affect change beyond both with the individual patients I was seeing, but also at a sort of population level. And that's why I ended up at HRSA. I've really enjoyed it. I saw patients for about 33 years, and I actually just stopped seeing patients last September.
All right, we're just going to jump right on in with our questions.
Okay, great. Well, I'll start in that case. So, Cece, you gave us a teaser there, but can you reflect on your different experiences with infant feeding, and also then pivot to discuss what were the most important factors about the support you received in your breast and chest feeding?
Yes. So my first pregnancy in 2010, that was a pregnancy that I experienced down south 2 years after my diagnosis. And I noticed such a stark difference. And, times changed and my position in the world it was a sense of, oh my goodness, you should just be grateful that you were able to have a child while living with HIV. And then a further gratitude should be given because you were able to give birth to this child vaginally. Breastfeeding, body feeding, chest feeding, none of that ever came into the conversation. It was assumed and demanded, commanded that I would formula feed. So that's essentially what I did. I got the opportunity, I got pregnant in 2021 and had to make the decision after being involved in so much of the work that was going on at the moment with breast and chest feeding advocacy for people who are living with HIV. I had to make this decision for myself. I was going to feed my child, and I wanted to feed from my body. I wanted to breastfeed my child. And although it wasn't an easy road, we got there. This pregnancy is 10, 11 years later. Medication has changed. Some policies, guidelines have changed. And I just got the opportunity to do what I thought was best for myself and my family. So the support that I received on that part of the question, the support from my providers, the providers I was with initially were not the ones that were going to be who supported me for the entirety of my pregnancy or postpartum. I had to change that. So I found providers who would support me. Mental health support. I wouldn't be able to be here with you all today if I had not received some form of mental health support, which came in the form of therapy and community as my last support. Community was so important. There's other mothers living with HIV, such as Heather and Antoinette, who, helped make this journey that much easier because it's not an easy journey at all. As we got a chance to talk, Laura, a little bit, I got to learn from you, the shared decision making is this is what we should be doing. So are there any Ryan White policies that support the medical community to engage in shared decision making with parents in their decision to breast or chest feed?
Yes, so that is a really important question. So I think that all the best ongoing medical care involves a partnership between a patient and the provider. And patients that don't have that should look for a new provider, and not all patients are situated in a place where they can. As you said, there are just places where the culture is different or where there's not a lot of access to providers. But I think on the whole, shared decision-making probably happens better in HIV care than potentially other parts of medicine, in part because of the roots. of advocacy and patients' voices in terms of getting early drugs approved and really being at the table in terms of making decisions as we move through HIV, the evolution of HIV care. So like for me, when I first started, patients were getting sick and dying very, very quickly of HIV. So my job was to really understand their values and provide end-of-life care. And that is all about patients' values and patients' priorities. But thankfully, we are at a very different point now in terms of HIV care and treatment with people living long, healthy lives with the virus. I think the most important tool that we have in the Ryan White program is the Ryan White statute, our law that runs the program and governs people that are getting funding from us, is that providers need to provide care consistent with the guidelines, which is why it's so important that the guidelines are so very specific about the shared decision-making. That said, I think we now have a little bit of a gap that we need to fill around developing tools, both for people that are pregnant and thinking about what their feeding choices are, as well as providers, to educate them both about the risks and benefits of breast or chest feeding, so that both can come fully armed with knowledge and facts to that discussion, to be able to talk about the values and priorities of that individual person who's going to be giving birth. So, so we really need to make sure when we do have the law behind us in terms of this is what the guidelines say. And on top of that, now we really need some good information so that providers are armed, because for many providers, it is a sea change for them. Like, I don't think they've learned this. This is the way it's been for so many years, that this change is something they need to know about. So I'm going to go and ask you another question that really comes from that. So what do you think is, from your perspective, the best way to educate the medical community about these new guidelines? Because that is going to be critical to make sure that this happens well and seamlessly for patients.
Well, first, I think it's conversations like these, just conversations, listening to the communities that you're serving. A lot of times, we'll find out about the information. Sometimes we're presenting the information to our providers for the first time. So listening and not just throwing it away with a grain of salt. I think beginning to personalize and humanize people who are living with HIV, and I'll speak from the point of a woman who is living with HIV, putting yourself in that place and, just going to go seek the knowledge because this person is coming to you with this, and because this is so important to this person. And then you'll be able to see, that these guidelines are really making huge waves and differences for people who are living with HIV. I think, once again, these conversations where, probably Laura and I might not have had an opportunity to meet outside of this, but I think that these exchanges are really, really important.
Yeah, no, I completely agree. It's that patient-centered care too, like listening, the patient, one, being able to advocate for themselves and know about this change, and then providers listening to what their patients are saying.
Yay. All right, so I'll go into my last question for you. I'm just admire the work that you've done, and I know that you've been in this work for a long time, and you've got to see the tide change for so many things, including now breast and chest feeding and HIV. Do you have any suggestions for how we get the news of these guidelines out to the people who need to see it, such as those providers, social workers, people living with HIV?
Yeah, so that's a great question. When you look at the history of HIV treatment, we have really been very, very quick to adopt advances. Most changes in medical technology take 10 or 15 years to be widely adopted, and that has never really happened in HIV. And I think the advantage we've had in HIV is the development of treatment guidelines by the US government, which has happened since very early in the epidemic. And as I said, that law that people in the Ryan White program need to provide care consistent with those guidelines. So within the Ryan White program, we're also really fortunate that we touch this program, the Ryan White program, touches over half of all the people with diagnosed HIV in the United States. So the impact can be really big if we can leverage the Ryan White program. So we've been really tried to be very thorough in making sure that all of our recipients know about these changing guidelines. We've had webinars, we've had coffee chats, at all sorts of different levels with our recipients. We've made sure all of our staff are aware, so as they're providing assistance to the recipients and grantees, they can make sure they know. And Dr. Levison was able to speak at our Ryan White Clinical Conference last year. We trained about 400 providers in that meeting, so that was really important as well. We have an arm called the AIDS Education and Training Centers, which is also really focused on clinicians, but case managers, people throughout the Ryan White program to make sure that they're educated. The other piece outside of the Ryan White program is HRSA, the Health Resources and Services Administration, where I work, also funds the Health Center program, the Maternal and Child Health Title V block grant that provides services through every state and touches almost every pregnant woman in the country in some way. The Federal Office of Rural Health Policy. So we've really sent out a ton of information through all of those channels. Mindy Golat, that works for me, has really been in charge of doing that and done a fabulous job. And because the federal government, we've been able to leverage the White House, and we've gotten them, the Office of National AIDS Policy, to make sure they're reaching out to the parts of government that fund child protective services to make sure that piece, which I think is critically important, is also happening. So just there are lots of different ways we do it. We have less direct access or engagement with patients from where we sit in the federal government. So it's really important that we think how we can provide that support and where those, because we need those tools available. So that is something that we're still working on and thinking of and figuring out where in the federal government, from where I sit, those connections can happen.
Yes, and thank you for that. I see some comments coming up in the chat. Just going to go ahead. So I love talking this piece about like patient-centered care in the field of HIV treatment and care that was brought up by Fatima. I feel like that is so important because as a patient, I think we're all patients at some point, like we have done this. So, you know, how would you like to be treated when you go into a provider's office? And I love talking the piece of bodily autonomy when it comes to people living with HIV and the stigma that still persists clearly, because if we're saying that we have the support from here, we're having the support from here, what are the reasons in so many different ways that why is the opposition still there? So I'm grateful for these guidelines. I'm grateful for this conversation. I don't know. I can bring up this question from Mariah. I don't know if this is one for you because I can't answer it. How are FEMR boards being engaged? Was that what you answered?
Yeah, so FEMR boards, fetal infant mortality review boards, I think is what it stands for. And a lot of different states and jurisdictions have these, which is where if something happens that has a bad outcome in some way, that you really go and try to figure out what those root causes are. So that is a great question, Mariah. We have not specifically engaged FEMRs, but I think it makes sense to do that as well. So we can definitely look into that in those people that are funding those to happen. Some of that is through the maternal and child health block grant. Sometimes are funded FEMRs in part. So we'll definitely look into that on the HRSA side.
Well, I feel like we have come and did what we were supposed to do. I'm done with my questions to you, Laura. Thank you so much. Thank you.
Yeah, it's been a pleasure working with you and so great to have met you here. So thank you as well. And thanks everyone for signing on today. This is a really important topic. So it's great that we have a group of people engaged here.
Yes, again, thank you both so much for just sometimes it feels just bottomless kind of well of wisdom and experience that you both bring. I'll just move right into introducing our next pair of panelists in conversation. I have the honor of introducing Antoinette Jones and Dr. Natella Rachmanina. Antoinette Jones began her work with HIV advocacy in her early 20s as a peer navigator, facilitating access to preventive care and treatment for people living with and at risk for HIV. She identifies as a vertical woman living with HIV, meaning she has been living with HIV since birth. And Antoinette is part of the Dandelions movement, co-founder, I believe, which centers the needs of people born with HIV through mentorship, healing, and peer-to-peer interventions. Welcome, Antoinette. Thank you so much for being here. And Dr. Natella Rachmanina is a professor of pediatrics at the George Washington University. And serves as a director of the HIV program at Children's National Hospital in Washington, D.C. Among many other roles, Dr. Rachmanina is a chair of the Committee on Pediatric AIDS at the American Academy of Pediatrics and a member of the U.S. Department of Health and Human Services panel on the Pediatric Antiretroviral Therapy and Management Guidelines. It's a mouthful. And if memory serves, I believe that you two go back a ways. I'm just going to mute and thank you so much for this conversation.
Awesome. Thank you, Olivia, for that wonderful introduction. I'm so happy to share space with Dr. Rachmanina. Like you said, we go way back. So it was such an honor and a surprise to share space and have this conversation with somebody who actually knew me as a young person, and all of my advocacy journey. So just a little bit about me. I am somebody who's considered a dandelion. That is a term that we coined. And it's also in other terms used as verticals, or people who are perinatally diagnosed with HIV. I have been living and thriving with HIV for 28 years. And I have a lovely baby who's about to be 2 years old in August, who I had the pleasure of breastfeeding, and really just shift how I advocate for myself and show up around this issue for breast and chest feeding. And I'm gonna pass it to Dr. Rachmanina.
Well, thank you very much, Antoinette. First of all, it's honor mine. It's an amazing experience to sit with you on the panel, to remember you as an extremely cute little girl, to remember your mom, to remember the conversations we have, to see you as a thriving, beautiful mother, and to hear your advocacy voice and to see your bravery and your integrity and your incredible strength to not only live and become mom and bypass all the hurdles of dealing with a lifelong health condition, but become an advocate to whom we as providers appeal for support, listen, and learn and continue learning. So truly my honor. I would like to start our panel discussion by asking you, how did you come up to the idea of breastfeeding, how it came into your life when the pregnancy, obviously we were with you at the journey before your pregnancy, and you went to adult care out of our pediatric care. And I'm really interested to know, I know we never had this discussion with you. We had discussions about reproductive choices and partnerships and sex with other person and potentially getting pregnant. We never talked about breastfeeding. So could you tell us a little bit how it came? What were your challenges? Were the providers supportive of you or not?
Well, thank you. That's a great question. I feel like I was always a very strong-headed and stubborn child. So and I knew of the recommendations when I was young, but I always knew that I was going to breastfeed. I always knew that no matter what, I'm going to do whatever I want, whatever I say, because I just knew how my body was. And then I knew I wanted to do something that I didn't understand why breast and chest feeding was happening so often in other countries and wasn't able to happen here in the US. So when I became pregnant with my daughter, Lyric, I was like, oh, I'm breastfeeding. And shout out to my mom. She's on the call. Hey, Mom. But I told her immediately, I was like, I'm going to breastfeed. And she was like, well, just talk to your doctor and whatever and let them help you throughout that process. And I just knew from the beginning, from a very young age, that I wanted to have children. I wanted to change the narrative. I wanted to show a different light for people who were born with HIV and not continue that generational, what people may consider generational curse. So I knew my baby was going to come out negative, and I knew that I wanted to do something in addition to that to prove that HIV isn't what people think it was, and that we actually, people who have a lived experience, are the science. We create the science based on our own experiences.
Well, that's wonderful to hear. So I'm ready for your question, but probably one more to just ask you. Was viral load an important driver for you, or was there something that was stronger than just the lab value to you?
Oh, viral load was definitely important. And it wasn't just the providers telling me that I needed to have an undetectable viral load in order to make the decision to breastfeed. But I just knew based on my own experiences. My biological mother didn't know about her status when she gave birth to me. And unfortunately, during that time, her viral load was through the roof. You know, she didn't have access to AZTs. I was just born right at, I like to say that when I was born, it was like right when they created or offered AZTs to prevent mother-to-child transmission. So I had just missed the mark, right? So for me, it was super important to make sure I was undetectable. But in all transparency and honesty, I struggled with adherence my whole entire life. We could get into that more throughout our conversation because I know you remember some of that, the challenges that I faced. So I think like when I think about you as my provider and y'all, it goes way back like the age of 14 to right when I aged out of pediatric care at 18. I knew I could have children born HIV free because of like some of the conversations that you mentioned that we had around sex and like and partners and like disclosure and like or just sharing my status with the partner. But how do you think those conversations around transmission will shift with provider and patients, very similar to ours now that breastfeeding recommendations have been updated?
Yeah, that's a good question. And I represent a rather stubborn community of pediatricians, and we're very protective, and we tend to treat our patients in a very protective kind of child way. Don't jump off this cliff, don't go on that surfing, wear the helmet. So that helmet of not breastfeeding is coming off and we're taking more risk. Does it come with some anxiety on our end? For sure. And I do want to acknowledge that anxiety. And in some comments, I think we will see it. It's normal. It's a transition of no more risk for transmission after birth and postnatal prophylaxis is done, to going on a journey together and taking some risks, and particularly in the scenario if there is a viral load blip, which was already actually even came up during earlier presentation today on the panel. How do you deal with it? What is your value? What do you accept? Which combination of medicines you do? I do think pediatricians play a very big role because our focus historically and by nature of our practice is on the child primarily. There are great benefits of breastfeeding to the child as well. We recognize them, but they're also not zero, and we want zero risk for as much as possible. So I think, and I would like to really highlight the work by my colleagues at the Committee on Pediatric and Adolescent HIV, the American Academy of Pediatrics. We have developed a breastfeeding guidelines now, which is very much harmonized with what you heard Dr. Lemonson present today in the national guidelines. And it also involves breastfeeding section at the American Academy of Pediatrics. We hope to release it this year. We're working very hard on meeting the certain publication deadlines and help leverage that conversation with a pediatric provider community, which has been taught so many years through the national guidelines not to allow breastfeeding, which has been taught also to protect the child, and Child Protective Services is a mechanism we go to historically for any other forms of neglect or child maltreatment. It's a complete rewire of the provider mentality, and many providers are ready, but many need some more information, more assurances. So I think there is a lot of work still to be done. I think advocacy of patients, advocacy of people like you, advocacy of mothers is a very, very important voice. We are moving from being more prescriptive providers in general, I think, in this nation, to being more teamwork providers. From primary care to subspecialty, we have to recognize that. And I think this is very important conversation to take forward and to leverage this decision-making. The most appealing wording in everything we discussed to me, it is truly shared decision-making. It should not be me prescribing anyone what to do. It should be conversation, mutual conversation. It needs to repeat many times. I want to allude very briefly to Judy's point and earlier question, 50 copies. We had breastfeeding moms who had 60 copies. We continued breastfeeding in our practice. Did I go to color my hair sooner in that month? Probably yes, because I was nervous over this time, but the mother is suppressed and it was just a very short blip. And we all lived through that. Breastfeeding was never interrupted. It will take adjustment on our end. And I just want us all to ask for patience, be supportive of providers, engage them in this conversation. And it is very important that all of us talk about this all the time. It's not a conversation should take 3 months post guidelines and then stops and we assume everybody knows what to do. But I think we just need to continue this dialogue. Back to you, Antoinette, because I want to ask you whether you continue this dialogue with other providers as well. I know we're in touch.
Yes, I do. I remember telling my pediatrician for Lyric when she was walking me through all the risk and just a PowerPoint of like the studies in Africa, the PROMISE study and all of these things. I said, well, you know, in 5 years, you're not really going to be showing me this stuff. Like in 5 years, it won't feel as scary as it is, this conversation that we're having. You won't really be talking about risk so much, but you will more so be moving towards conversation around like, and more exciting conversations of like, this is what you can do now that you're breastfeeding. This is what your baby will benefit from you breastfeeding versus like, this is what could happen. And that ultimately like impacted me in the way that I was breastfeeding and how much internalized stigma that I've suffered from. So I'm really excited for those conversations in those patient settings to shift. I do work a lot with providers, but I mainly work with the patients. I think the patients are super important in understanding the fact that they can advocate for themselves. You know, ongoingly, I had struggles with my adherence in the beginning of my pregnancy, and they use scare tactics. Well, if you don't get undetectable, then you aren't going to breastfeed, and we don't even think you should breastfeed anyway. And some of those, like that type of language and like you said, like talking down on the patient, it doesn't work. It didn't make me feel more comfortable, especially being somebody who has had to go to the doctor my whole entire life and suffering from provider fatigue and medication fatigue, but also knowing that I wanted to have a negative baby. But with bringing up some of those challenges, and I'm sure you remember them because at the providers where I met you at, the way that I was able to become undetectable was they started to pay me, okay? They started to give me money, and every time I came in with an undetectable virus, but I needed that money as a young person to afford to live, you know? So I wonder, like, what are some recommendations that you may have for providers who are dealing with patients who do deal with adherence issues? Or any other type of like stigmas or things that are preventing them to reach that undetectable viral load when they want to?
I think an ideal word, Antoinette, the pediatric provider, and I will speak now from the lens of pediatric providers, should be involved in that conversation during pregnancy, even better before. But during pregnancy, I think the combination of having obstetric, gynecology, or infectious disease provider, primary care provider who takes care of mom and pediatrician together, I think, first of all, could be a wonderful catalyst for a woman to really see the benefits of becoming undetectable and throughout not only pregnancy, but through postpartum period. So I think I've seen examples where breastfeeding becomes a motivator, or desire to breastfeed becomes a strong motivator for women to be more adherent. Also, I've seen women who just had a hard period, as you said, stigma, being abandoned by the partner in postpartum period, which is fragile and difficult. And dropping the adherence temporary and dropping the breastfeeding at the same time could feel almost like a punishment. And so I just would want to say that ongoing questions to each other. What is your problem? How can I support your adherence? Can we maybe face with each other once a day, or additional resources? People mentioned that. I hope we really recognize there will be circumstance where additional resources are required and need to be invested, but being with women through their journey. If the situation comes to stopping breastfeeding, maybe not giving up for hope, continuing pumping and re-achieving viral suppression and then reconsidering, or weaning the baby, but weaning the baby in a joint team effort. So not leaving women alone with her struggle. That's most important to me.
Definitely.
I know we're at the time. I'm turning back to you to close our conversation. And again, just a joy to see you. And you owe me more new
Definitely.
pictures of the baby, because I only have the older ones.
Yes, I do. I do. Thank you so much. I can't wait for our breakout conversation, because some more questions that I have was around the baby, like, and the medications and how much it affects her. And I know a lot of mothers and people in the chat may have some similar questions. So I look forward to our breakout conversation. I'm like very excited for that. But thank you again. Thank you so much. I look forward to us connecting some more, and then continuing this conversation in a very unique way that centers people who were born with HIV and how they too have hope to breastfeed and have a chance. So thank you.
Thank you.
Thank you both so much. That was an incredible conversation. And thank you, Antoinette, for making sure that folks realize that they can continue the conversation with both you and Dr. Rachmanina in the breakout session. We have one more panel, and I am delighted to introduce Heather O'Connor, who is the communication specialist for Ribbon, which is a nonprofit, and also Leslie McGorman, who is the Director of Public Policy for the American Academy of HIV Medicine. The details of the many, many, many accomplishments of both of these amazing people are in the bio document that has been dropped in the chat. Heather and Leslie, can I ask you both to give a little bit more of an intro to you and what brought you into this discussion, to yourselves and what brought you into this discussion before you start your questions for each other?
Sure. My name is Heather O'Connor. I use she, her pronouns. I work for two separate nonprofit organizations that both deal with people living with HIV. I am a mother. I'm also living with HIV and have been since 2016. I have two babies, a 2-year-old and a 4-year-old, and both of them I breastfed for 14 months, and they're both HIV negative and very healthy and vibrant. Yeah, and I'm very passionate about this subject. I sit on the perinatal panel, and so I'm so thankful to have been involved in the process of the updating of the guidelines and acknowledge how incredibly important it is for parents living with HIV and providers alike. So happy to be here. Thank you.
So nice to join you, Heather, on this panel, and thanks to Marlisa and everyone. It's just a delight so far to be in this shared space with so many just really incredible people. I am Leslie McGorman, as you heard, the Public Policy Director for the American Academy of HIV Medicine, and we are a membership organization that represents providers in the HIV clinical care team, so physicians, nurse practitioners, physician assistants, and pharmacists. And I'm here today because I want to be able to share all of the ways that we're helping to sort of equip providers to follow these guidelines, but also to sort of maybe do better in embracing them so we can get there sort of more quickly. But on a personal level, I just have really benefited from having really involved board members and colleagues that helped sort of bring us to this conversation today. But also I know it's just a truly important sea change to have so many stakeholders involved in drafting guidelines like you, Heather, and being able to just again bring that to the providers in HIV. So thank you again for having me.
So I just wanted to start out with a question that I have that's come up a lot. I also work for the Well Project, and I am a moderator of a support group for women living with HIV with an interest in breast and chest feeding. And I've come across a lot of mothers who have experienced disclosing that they would like to breastfeed and that that's something that they see in their future. And they've had supportive providers throughout the process. And then as it gets closer to birth, the provider changes their mind and there's sort of hesitancy there. So how would you, and your standing and what you do in your profession, support a provider who is attempting to adhere to these guidelines, but has sort of a personal hesitancy to support the parent who's wishing to breast or chest feed?
Yeah, that's such a great question. And I think that we've heard a little bit of it from panelists before who are on the clinical side. What I would say that for my organization, we have a number of mechanisms to educate other providers. So I think that Dr. Cheever even said HIV specialists and providers are sort of really well positioned already to do some of this education for other care providers, you know, sort of throughout the pregnancy and the delivery process. But I think that organizations like mine play an important role because they create the community. So we obviously give access to educational materials, webinars, statements, the guidelines themselves, provider community where they can ask questions similar to the perinatal hotline. But I think that what you're getting at with just sharing those experiences is that there really is no ceiling to what we could and should be doing. We really need to be reminding all types of care providers and disseminating this information as widely as we can, as frequently as we can. We know that that is a terrible outcome for a pregnant person to be sort of confronted with that risk to like the continuity of care and to having a trusted provider. I'd love to hear you speak about that as well. But I think that really we cannot do enough work to disseminate this information and make sure that providers also have the support that they need to be able to maybe confide in their peers about that discomfort without expressing that discomfort with the patient. I sort of feel like that should be the last sort of, sounding board that you have. And we definitely are like doing our part and really trying to conceive of other ways to broaden that reach. But turning that back, if you would indulge us, Heather, in maybe starting with what being able to breastfeed has really meant to you, and sort of maybe the role that that articulation can play in helping to bring providers along to that place of comfort. Because I think that what we can acknowledge is that it's perhaps not based on fact entirely, but that there's a lot of maybe an emotional component of that as well.
Absolutely. I always share in my story that immediately after being diagnosed, I was very ignorant to a lot of education about HIV. And so my first question to my provider was whether or not I was going to die. And then my second question was, will I ever be able to be a mother? And when I found out that I was able to be a mother, I was ready to adhere to whatever providers told me that I should or shouldn't do to keep my child HIV negative. So when I came to my provider for the first time being pregnant, I was actually asked by him how I chose to feed my baby, and I felt like I was being tested and immediately said, I'm using formula. I know I'm going to use formula. And that's when he actually educated me on the PROMISE studies and explained to me that breastfeeding could be an option, and I'd been undetectable since a few months after being diagnosed, and that it was something that I could do. And I think my own self-stigma after being diagnosed sort of left me with this visualization that my blood was toxic. And that I was toxic from the inside, and that toxicity made me different from other people who were not living with HIV. And that's the self-stigma that I lived with every single day. And so then when you put that in the context of me bringing another life into the world, immediately I thought, well, my milk must be toxic too. And so I really struggled with that thought and went back and forth multiple times, along with, you go to research HIV and breastfeeding, and at the time the guidelines were not updated. The first thing you see is the CDC recommends if you're living with HIV, do not breastfeed. And then it's followed by the World Health Organization's recommendations to exclusively breastfeed for 6 months, and if mother's on antiretroviral treatment. So I was very conflicted there. But I think that the idea that my body could produce nutrients for my baby and have that be the perfect protein, sugars, all of the active antibodies in my milk, and could do start my child off on the best foot, be the healthiest thing for my child, was a rebirth for me, because then my body was doing something that I wanted it to do. And my body was doing something it was supposed to do naturally. And by me adhering to my medication, I was able to be in control of that. And so it gave me a sense of control and a sense of agency in being a parent and making those decisions for my child. And so I really think that shift there into, I'm no longer toxic to my baby, and I can make decisions that are good for my baby. And I know the science and I can trust the science. And I had support behind that as well. So that was the biggest shift for me. And that was the emotional part of it. Breastfeeding is the best experience that I've had in my life, aside from having my children. And I would do it again 1,000 times over. And I will advocate for every mother and birthing parent living with HIV who chooses to take that same journey. I have a question for you.
Okay, because I have another question for you.
Okay, cool. Do you want to go first?
Go ahead.
Okay. One of the things that I've encountered a lot with parents living with HIV who choose to breast or chest feed is that they're met with this idea that if they receive support from their provider, they're somehow being allowed to breast or chest feed and being given permission. And so oftentimes that can feel like such a win, you know, even if it really does feel like sometimes you're being thrown a bone, you're still being allowed to carry out that journey. But then you get to the hospital and you deliver and you have to figure out how to breast and chest feed, which can be extremely difficult and at times can be the end of breast or chest feeding because you don't have that lactation support. So in what ways can providers help to sort of integrate care with lactation professionals to give that full, well-rounded support to make sure that these breast and chest feeding journeys are successful?
Yeah, I mean, that was very close to the question I was going to ask you. We're very in sync today because I've heard you share a lot of wisdom about sort of getting beyond the yes. So I'm going to answer your question, but I'd love if you could pick up that side of it, because I think you counsel women early, and I think you do it in a way that may be more effective than some of the providers. And so it would be a good lesson, I think, for the folks who are actually providing care. But I think it's not dissimilar to, you know, sort of what we talked about earlier with just the importance of these new guidelines and really disseminating information widely. But I would add to it, the real beauty of these guidelines is that I think that through language and through the shift in language, it has really, I think, encouraged providers to just humanize their care a little bit more. And I think we all love to assume that every provider is wonderful and they're doing perfectly and they use great language and they really provide a nurturing, comforting environment. But you mentioned the larger team, and it just is not accurate to assume that every provider, every person on that team, lactation delivery, what have you, is, you know, equally knowledgeable about these issues. And so really what I think that providers ought to focus on is that compassionate, supportive environment, that nurturing environment that also, I mean, the real crux of shared decision-making, that we're not just focused on science, we're focused on real human beings here. And particularly with just I don't even really have great language to describe it, but just like giving birth and then having the opportunity to breastfeed a baby, like that's something that is not, you know, we can no longer talk about science. And so I think providers really would benefit and really do better for their patients by remembering that piece, you know, that really if we like sort of lead with our hearts and know that they have the backing of science, that they can educate teams and really really force a really positive experience for the person that's giving birth. And I'll leave like sort of the clinical, you know, components of that to the clinical folks we've already heard today, but that's my feeling about how, you know, we can add a really important dimension onto the clinical care. But yes, if you could talk about, in the last couple minutes we have of like the importance of getting beyond yes, and sort of your answer to the question you asked me.
Yeah, absolutely. And I just will say that for any person living with HIV or not living with HIV, breast and chest feeding is a very difficult thing. You think of it as such an innate thing. You have a baby, you feed the baby, but there are things that go into it, you know, getting insurance to approve a breast pump. So you have that at home ready for you if you need that for any reason. Getting baby to the breast as soon as possible after birth to get that milk flow going, to get that milk production going, and how to troubleshoot. You know, a lot of the times mothers think that my milk isn't coming in, but you know, baby's getting just enough milk, but there's that anxiety if you're living with HIV because you want to steer away from the mixed feeding and exclusively breastfeed, you know. And so I think that the biggest thing, the biggest learning moment that I've had is that lactation support is so incredibly important. They must be educated, they must be on board, ready to support, to give that hands-on help with latching after birth, make sure that mom has everything that they need, you know, to go home and to be successful, and then care beyond that. You know, a mother or birthing parent wants to know that if they call a lactation hotline, that they're not going to be reported to CPS for disclosing their status. So the education has to go beyond the provider to the lactation consultant, to all people who are going to be involved in every aspect of the breast and chest feeding experience for the mom or birthing parent who's choosing to do so. So I think that's so important. Thank you for that question.
And I think we're out of time, though I know we could talk for probably 2 hours. I do want to just say, though, we didn't have time to talk deeply about the CPS piece, but I will put it out to all providers that I think we all know the consequences of that are so high and potentially very, very damaging to the family, but that doesn't stop with them as individual providers. It should be conveyed to the full team, as you said. So thank you again, Heather. It's a delight to talk to you.
Thank you, Leslie. So thankful to share space with you.
Likewise.
Thank you both so much for another just super engaging conversation and just really connective conversation. We have just a few minutes for questions for all of our panelists before we get into the kind of meaty breakout conversations. I have questions sort of gathered here from the chat, and I also do want to call attention to the survey link that is in the chat right now, anticipating that we hope to keep all of you here, but as you are leaving, if you have to go do something else before the end of the session, we wanted to make sure that folks have the opportunity to fill out the survey at any point. So that's right there. So questions going back to Laura and Cece's conversation. Dr. Cheever, are you able to address the comment above about the Florida Department of Health not yet supporting breast and chest feeding for people living with HIV? That was the gist of the comment. It's a long comment, but you've got, okay.
Yeah. So I read the comment. Yeah, so I do not have any information about that at present, but it certainly has raised questions for us at HRSA about what we can do to help support states, in those transitions. I do not believe there won't be any like new money in most places to support this activity. And so how can we leverage other resources we have like the AETCs and others to help us with this? So it was a great question and raised a lot of questions for us. So thanks for that.
Excellent, thank you. So now another one. Hi, Cece. Excellent discussion. Thank you so much. In your experience, which support system helped you the most in the shared decision making for infant feeding?
Well, first I'll start with it was my providers. Getting a team of providers on my side, I felt like essentially what it was. It gave me the confidence to be able to speak out in front of people. It gave me the confidence to go back and speak to my family and give them information back to other folks in the community. So without that, I think it would have been a little harder to navigate because I'm definitely terrified of a CPS call.
Exactly, absolutely. Thank you for that. Thank both of you. This question is for Antoinette and Natella, but could really be for everyone. Do we or anyone who has the answer, do we have perinatal patient-centered care trainings or curriculums?
So I will start. I know that there have been a series of webinars held by many organizations that provide HIV education. I want to echo another comment made. I apologize, I didn't catch the name, that we need to reach primary care providers audience, which so far we focus a lot on HIV related care centers. So to my knowledge, there is no universal national curriculum at that point. I do know there have been a couple of really great papers just published, and I'm happy to disseminate Lee and everybody. Marlies, you probably have seen Hopkins just published a paper, and Lisa Boje group from Colorado just published a paper on the model in clinical practice of doing the breastfeeding support, sharing some of the algorithms and educational materials. But to my knowledge, there is no national course. I can tell you AAP is preparing, as we relieve our very harmonized guidelines, to have a wide nationwide webinars for pediatric providers. So I do know we're in process of working on that, but probably need to do more to educate primary care providers. That's a comment from me. Back to you, Mark.
Thank you so much for that, Dr. Rachmanina. We definitely are pulling together those articles that are being released, have recently been released, and are in the process of being released, and we'll be circulating them to all the registrants of this session.
Perfect. Thank you so much. One more question. Though the guidelines recommend nevirapine after the 6-week period of triple ARVs, there are some that support the use of zidovudine and nevirapine, and more recently, some that only use zidovudine. Can a consensus be supported, or better explain the decision for nevirapine alone? And I believe that question is, again, if it feels like you're well positioned to answer the question, I think probably Judy, or yeah, please feel free to jump in.
You know, we just don't know about the prophylaxis. And right now, I think a lot depends on provider comfort. And sometimes, you know, people have heard me say, are we treating or providing prevention for the baby or for the clinician? I don't know. And so I think it's going to be, for us, it was our clinicians feel most comfortable with continuing nevirapine until a month after cessation of breastfeeding. But does that mean that that's the right thing, or that's necessary? It does not. So I think it's a great question, but we don't know the answer yet. And Ted, I don't know, you may have something to add to that.
Yeah, I would like to add a bit. I think, I mean, I agree with just what you say. The reason there is diversity of opinion is because there is no clear answer about one necessarily being better than the other. So we have to call that there's a need for research in that safe space, but then also how do we navigate it? Meanwhile, I think this, like all of this, really needs to be a shared decision-making process where both parents and providers talk through what their concerns are. If some parents, for instance, might want to prioritize minimizing any chance, like to have extra medicines on because they feel more comfortable with it, That's a reason to decide for more. Some people may have more concerns about toxicity. That's a reason to decide for less, but there's space for that decision because we don't have a strong single recommendation. So I think we really need to kind of engage with that as a choice for people to kind of weigh their values and talk about it with their providers. There are also questions about local availability about these medicines and other things like that also should be taken into consideration at local program levels, I think.
And we do just 2 weeks Zidovudin, what Judy just said. So practices are different, as Ted pointed out. And I agree with you wholeheartedly, Ted. Is a really discussion with the parental preferences. And sometimes you have to move from one to another. If you discontinued prophylaxis and the mother viral load blipped, you might want to reinstate prophylaxis after testing the baby, as particularly if she's going through a period of some challenges with adherence or needs to regain viral control. So it's all I want to say, it's a very mobile, very fluid, and very mutual process. There is no one clear script.
You beats 25 responses. Thank you so much. Did anyone have anything else to add? I don't want to cut anyone off. We have one more question, I believe. At least one more. How supportive were the fathers in your decision to breastfeed? Antoinette, Heather, Sierra. While we talk about shared decision making, at times we miss involving the fathers, supportive parents, etc. Good question.
Sorry. I would say Alert's dad was very supportive in our decision to breastfeed. He was only very concerned when I would like be bawling my eyes out coming from my doctor's appointments and just be like so upset and like emotional. That's when he would be like, "Are you sure this is something that you want to do?" But ultimately he put the decision in my hands. And he was like more than okay with it.
Yeah, I was fortunate to get to be able to take the lead, you know, and that I am an anchor for the information that those around me receive when it comes to HIV. So, you know, I get the information from the provider, I take it back to the community. That's why setting the tone from that provider's office, what I get, it sets the tone for a whole group of folks that are attached to me. So everyone felt safe and comfortable. I got the support. It would have been so hard. I can't imagine having to fight that, you know, when the other parent isn't on board.
My partner was extremely supportive in the way that we had to have the hard conversation of what if. And when what if was brought up, he told me that I am a strong woman living with HIV who is thriving in her life, and that if it just so happened that our baby were to end up in the same shoes as myself, then our baby would be just as strong as me. So we did have that conversation. He's awesome.
Brilliant. Thank you all so much. I believe these are our last questions. They involve infant prophylaxis, and I do want to point out that we've got a breakout room for that. So if you have more questions, you want to engage in conversation, there's a whole topical breakout just for around infant prophylaxis. So the questions are, I'll just ask them both that they're kind of related. Would long-term prophylaxis for the baby make occasional mixed feeding safer? What about toxicity of meds in mom's milk? And then yes, we will be talking about that later.
Ted, you put an answer in the chat about the medications first.
Yeah,
I don't know
I'm
if you
happy
want
to
to
answer.
answer out loud.
For sure, but I wasn't sure about if we're talking about it later. If you wanted to, I'm happy to talk about it. So my answer to Pamela, hi Pamela, by the way, is that, you know, I think it's logical to think that extra prophylaxis might reduce risk in that context. I mean, we know that, and what we've seen with prophylaxis in general to infants is if they take even single medicines, the ones we've studied most around 3TC and nevirapine and others, it really works well. So we would think if there were risk, it probably would provide an extra layer of protection. But I did want to acknowledge, as I said in the chat there, that in the context of a parent that has suppressed viral load, we're not even sure there's any increased risk with mixed feeding. So that's another thing that I think people have to kind of keep in consideration, you know, in that decision. And then the other question about toxicity in milk, I think that's what I'd welcome others to comment on as well. There is varying amounts of the medicines that a parent would take would get transferred to the milk and then to the infant. It is almost always, I'm saying that just because we can't be sure about everything, but we think far lower levels, of course, than it would ever be for an infant to ever be taking as treatment. But the question of whether that long-term exposure has any risk to the infant is a real one. I think there are some data to suggest not, but it's something that we have to put out there as a possibility. But of course, that's something that's been faced for some time now. And I welcome others. I don't know, Nutella or Judy, if you wanted to comment on that, or Ellen even, perhaps about the registry as well.
Very short comment from me that the new guidelines actually have for the first time table that you can use in counseling mothers. I think it's really nice table, very honest table, what we know, what we don't know, but at least the level of evidence we have for different drugs, toxicity, both in pregnancy, and the same applies to breastfeeding. So please, it's very clear table, it's not a complex medical table with a lot of numbers. It's really easy to navigate. And I echo everything you said, that the majority of the drugs penetration to breast milk is not very high at all. And we do know that millions of women breastfeed globally. So there is obviously need to collect more data. I fully agree. Hopefully Ellen will comment on that. But at the same time, so far, no major toxicity signals that we can associate with the breastfeeding exposure to at least most of the drugs that are used in the global settings. That's probably where I will stop. But evidence is not available for all the drugs.
I would agree with that. And just to point out that the FACT study, the pediatric HIV/AIDS cohort study, is studying long-term toxicity issues and has not seen any really serious long-term side effects thus far, but it's being looked at longitudinally. So we will have data over many, many years to follow.
Excellent. Thank you so much, everyone. Are there any other follow-ups? Is there a hand I'm missing? All right, I'll wait a beat. Hearing and seeing none. Time to transition into our breakout sessions. Just to give a brief introduction, we have 5 groups, 5 breakout sessions broken down by topics that folks selected and indicated being interested in when they registered. You're going to see a pop-up at some point soon listing those 5 topics, which I'll, unless I see, yeah, there you'll see a little pop-up that says join breakout room, and you'll see the topics, which are, as we discussed earlier, infant prophylaxis, protocols, shared decision-making, resources for providers, and resources for parents. You can choose, you don't necessarily have to go with the one that you chose when you registered. If you don't remember, just choose a topic that mirrors your work or your interest. The groups will be loosely facilitated and have a dedicated note taker. So no need to make those kinds of decisions. You can just focus on the conversation, and someone will be, one of the facilitators will report back for a couple of minutes at the end before we close. And again, you know, if you need help, if you are confused, if you are just needing anything from the moderators or tech support, you can just return to the main room. You should have a little thing to click on if there's an issue, if you get, you know, lost in the maze. It's not really a maze. It's easy to get to the breakout.
Hi, everyone. Welcome back. I had to check my chart to see if I'm running this session. So that's me. It's my turn. Thanks, everyone, for coming back. Judy was like mid-sentence finishing her story. I almost want to let you finish, but I'm sure that's true for lots of folks too. So why don't we, in our last 5 minutes, let's do a quick, or 3 minutes, let's do a quick round, and let's have each group give like your top amazing takeaway message from your group. Let's start with infant prophylaxis because they're just at the top of my list here.
I can take that. So we had a great discussion, and we heard both about some experiences that patients had with providers not recognizing some of the newer guidelines and how to approach breast and chest feeding. And so we really talked about the importance of communication between not just the providers that are taking care of the patient, but everyone surrounding the entire pregnancy and delivery and infant care issue. So that communication is really the key, and education of everyone to help support our folks.
Thank you so much. And what about the protocols group?
Well, we had a limited discussion around the actual protocols. It sounds like we're introducing each other to each other. And so I think that one of the takeaways is that a lot of the protocols are still in development. And so there's not probably a lot that are, out there and already in progress, but that that there would be a need to have kind of a central database of like when they are published and people are willing to share them, to have a place that everyone could access them. And the Well Project is willing to be one of those places, but that would be a really helpful thing to be able to have people access different people's protocols. And we dropped a couple of links into recent ones that are shared by Johns Hopkins in Colorado.
Thanks so much. And we will be collecting all these resources and sharing them with everyone who's registered afterwards. And resources for parents.
So we had a fabulous conversation, and I think that the overall theme of our group, like resounding message, was just how incredibly important support is from all different ends. We had a very supportive lactation consultant in our group, so thank you. We need you. And we had a very supportive, powerful mother in our group, and we heard from her. And thank you. We need you. And also, one of the biggest points that was brought up is that it has been an experience of some people that they look on the internet about HIV and breastfeeding and are still seeing the CDC guideline that says do not breastfeed, which big red flag shouldn't be there. So if you do come across this in any place on the internet that can be seen, please alert Marlisa or Leela. There are people who can contact CDC and make sure that that gets changed, because we don't want that. We definitely don't want that anymore. So yeah. It was a great group.
Thank you so much for that, Heather. And our last two groups, let's resources for healthcare folks, for healthcare providers.
Yeah, so we had a good discussion. We talked about the fact that there's more information on the safety of mixed feeding needed, obviously more resources for that. We talked about, and one of the things that came up was that apparently there are some clinicians that believe that no one exclusively breastfeeds anymore. And so therefore these conversations are not important. And that's actually surprising to me. And it is something that needs to be discussed. And then in a twofold kind of thing, we talked about the importance of having discussions early about with parents who choose to breast or chest feed, and then making sure that the plan is in place and disseminated. And if there's not currently a way to do that, coming up with some protocols and a plan to make sure that happens.
Thank you, Bridget, and thank you all for staying one more minute longer. Who from our shared decision-making group wants to report out?
So real quick. So one of the biggest takeaways that I just took away from that was one of the women in the group said, yes, finally, after 30 years, there are so many women that can come out of the shadows, which was extremely disheartening, which we knew was happening anyway. people living with HIV, whether supported or not, are going to do what they want to do. And they should be able to share that openly with the providers and the people that see them. How many people have we done a disservice to because they had to do it in the shadows? So that was one big takeaway. We got to talk about oh, what else? I was so hyped over that one about the agreements that would Judy got cut off on really quickly. I feel like that's a discussion that will have to happen more at another time. And how this shared decision making idea concept is very well appreciated from the people who are living with HIV.
Thank you, Paul, for that. That was this has been an amazing session. I so appreciate you. And just, I know we're over, but I just want to offer so much gratitude. This is an enormous effort, and we build it, and you all come every year, and I'm always honored that that happens. I want to offer a couple direct thanks to our people in the background, Brenda Goldhammer, Hua Su, and Dorothy Wang, who helped us like make everything run smoothly in the background. Thank you, thank you, thank you so much. I appreciate you. Our panelists who speak from pain and from joy and from being amazingly, beautifully human. I'm so grateful for your willingness to share your stories. And my gonna get reclamped here. My partners in crime, Olivia and Leela, you all, Olivia literally talked me down 3 times today. So like this absolutely could not happen without all of you and your support. Our amazing facilitators and note takers, thank you, thank you, thank you. And most importantly, really all of you who showed up and gave us a couple hours of your time. We're building the community and bringing everybody into the conversation to figure this out and work through it together. And that, I think, is the most important part of all of this work. So thank you.
Thank you, Marlisa.
Thank you. And a huge shout out to Marlisa, who put this whole thing together, who made it happen, who makes it happen every year. Thank you. Thank you. Thank you. I am just so lucky to work with you. And I am just going to, we put some of the resources in the chat. I'm just going to share a couple of last slides with some of these links and emails. Give everyone a quick chance if you want to take a screenshot or a picture or write anything down. Again, the information on the perinatal HIV hotline and our other lines at the NCCC. And then a thank you to all of you. And again, a link to our SurveyMonkey. We really, really want your feedback so we can make this a better and bigger event every year. Should I play us out? Not me play us out. Should Beyonce play us out?
Absolutely.
Okay.
Please.